Yeah, okay, so they should be in. If they're not in, please get them in. The penalty will not be severe. If you forgot to do that for some reason. And I believe on Friday, our current event presentation starts. Does anyone know who signed up for Friday? I haven't checked those recently. Did anyone sign up for Friday? You what? Okay. Well, just double check that list, right? And if it's your turn to go, up next, you're coming up soon, and you want to send your article with me to check, you're just nervous about that, by all means, run that by me. I'll just might set it quick and say, yeah, this is fine to present. Also remember, one of the benefits of going first is you have first dibs on all available articles, right? And so, the article that you have chosen get presented, well then choose another one, right? I haven't had two people go on the same day, present, or have the same article yet. Maybe you guys will be the first. If that does happen, then we'll work something out, all right? Alyssa, can you make sure those comments about class things coming up get added into the chat box?
Yes, that's what.
Yes. Perfect. All right. Any other questions, comments, concerns?
So it's just any current event that, like in medicine or whatever we want to.
Something related to microbiology, right? Which is pretty broad, and it's supposed to be. It's not supposed to be like a primary research article.
Okay.
It's supposed to be something that I don't know, that you find on like Science Direct News or MSNBC News. You know what I mean? Like something that anybody out there that's not in microbiology class would read.
Okay.
Right? Just to kind of bring in relevant else. So I assume, right, one of the big ones right now is there's multiple COVID-19 vaccines going into the phase 3 trial. So that'd be kind of the low-hanging fruit. When I say low-hanging fruit, that's not bad. Like, that's so super interesting. But you should not have to rack your brain too hard to find something. Okay. Anybody else? Abby, you're good back there? All right. Morgan? All right. Well then, let's hit the ground running. And we'll see how far we can make it through the innate immune system today. If you remember, what's today? Monday, right? On Friday, we discussed, I started to discuss granulocytes. Holmes, what cell types are granulocytes? What are the innate immune cells that are granulocytes that we briefly discussed?
T cells?
But that is a cell in the immune system, so we're at least in the same city. Someone help them out. What are some granulocytes? Jay. Basophils, eosinophils, and neutrophils, right? Those are the granulocytes. We're going to revisit those and talk about those a little bit more specifically. Neutrophils, right? These are A granulocytes, right? So they lack granules. So this is going to be lymphocytes, right? One of which is a B cell that Holmes just mentioned. Again, one of the things we pointed out, and I would point this out if some of you decide at some point to take structural histology with me, and Hannah True and Alyssa in the backpack. No one else in here took it, right? Okay, I thought you were looking over there. I forgot somebody. One of the ways you identify these cells, right, on the microscope is you can see lymphocytes are about the same size, actually, the red blood cell. All the other cells of your immune system we've talked about are considerably bigger. So here you see a monocyte, right? When a monocyte leaves circulation and enters tissue, it becomes a dendritic cell or a macrophage. And we'll talk about them leaving tissue a little bit later today, hopefully. And you can see monocytes are actually the biggest of the white blood cells, and it's running somewhere between 3 and 4 times the size of a red blood cell. Okay. Got that? So if you take AMP2, you have to identify these white blood cells based on size and nucleus and the presence or lack of granules. If you take structural histology, I will also make you do that. Okay. So kind of quick on the function of some of these monocytes. So again, when they leave circulation, that's when they become macrophages or dendritic cells, right? Macrophages can be described as sentinel cells, right? So they are good at seeking and destroying and kind of patrolling whatever tissue they've entered, right? So again, I have tissue specific. So in some cases, right, once they enter the tissue, we give them a name, right, a specific name. And so if any of you have taken ANP1, right, one of the cells that you talked about in the nervous system is microglia. It's part of the neuroglia cells, which are helper cells. These are macrophages that reside within your nervous tissue, right? If you've taken ANP2, who's taken ANP2 in here? Did you guys look at Kupffer cells on slides at all? Do you remember? Okay, I don't think that you do. I can't remember. This is really my first time doing ANP2 lab. We haven't gotten there yet. Well, in structural histology, you do have to identify them, but these are resident macrophages that live in your liver. Now, just because you don't have fancy names for some of the other macrophages, right? You have resident macrophages that hang out in your respiratory tract, right? In your lungs specifically. You have resident macrophages that hang out in your pancreas, right? And so these cells go to these tissues and kind of patrol these tissues for any type of pathogenic threat, right? You then have dendritic cells, which could be described more as scouts. Dendritic cells are capable of phagocytizing, right? They are capable of destroying a pathogen, but their primary job, right, is to sample the environment and then report back to, and we'll get to this probably in the next unit, the adaptive immune system, report back to lymph nodes, right? So you guys have probably heard of lymph nodes. If you've been to the doctor, right, and you're complaining of a sore throat or some type of congestion, right, one of the first things they do is they come up here, kind of right under your jawbone and feel around. And if the lymph nodes are swollen, that means that you have cells that are reacting to some type of infection and they're dividing, right? So dendritic cells are reporting back to the lymph nodes, right, to activate other immune cells. And so we actually consider them the bridge between the adaptive and the innate immune system, right? We are going to revisit that multiple times. One of the things that I want you to take away from these next two units is, although they get presented as separate branches of the immune system, there is a lot of interplay between them, okay? And we'll talk about, right at the beginning of the next unit, very briefly, right, what happens when you're missing certain components from the innate immune system, what happens when you're missing certain components from the adaptive immune system. What you will see is an overall failure of the immune system because they rely so heavily on one another. Does anyone know what that's from? Thank you.
I do.
Who's that?
Nakaya?
You know what that is? What is it?
Is that from Cells at Work? Oh, I thought you meant the image. No, the,
Yeah, the image.
huh?
The image is from the Matrix.
Oh, it looks a lot like, have you watched the anime, The Cells at Work?
I have not.
You need to. You'll learn a little bit.
Alyssa, add it to my list. Thank you for someone who got that right. Okay, good. I think it was last fall, for the first time ever since I've been here, no one in the whole classroom got it. And it made me feel very, very old. And I'm not that old. But the Matrix 4 is in production. Are you excited? I don't know what to expect, but I think they went 2 Matrix movies too far the last time, but we'll see. Maybe we'll get it right in the 4th. Right, so dendritic cells, as I mentioned, right, one of their jobs is to kind of survey and present back, right? So we consider them professional antigen-presenting cells. That's their main job. You can classify macrophages in here too, right? Macrophages are able to present to the adaptive immune system to activate and inform, although, right, their primary function is mainly to eat and destroy. You'll also see, and we'll talk about this next unit, B cells can also present antigen. They kind of have a unique kind of role that we'll touch on, right? So you digest phagocytized material, right? And again, we'll talk about this more. We'll talk about this more in the next unit, but when you phagocytize something and you break it down, right, two things happen. You expel the waste of what you destroyed, and or you present small fragments of what you destroyed on your surface. And those fragments that you present on your surface inform other cells of the immune system what needs to happen. And again, I know that for some of you that haven't had any type of immunology, that might sound a little far out there, but we will touch on that in the next unit. You'll see exactly how that happens. And if you really, really love that too, well, I don't know if they'll teach it for you guys, but Dr. Chrisman does immunology, and you go into all of this in much greater detail, right? So the thing that's interesting about macrophages, and you'll see in a second, you can throw dendritic cells in here, is, again, they are hanging out in the tissue waiting for something to happen. And so they can be active for weeks to months, and once they're activated, they can be around for days to weeks. If some of you have taken cell bio, and I don't know if this is discussed in cell bio much, but this is a very long lifespan for a cell in your body, all right? Turnover of most of your cells, even when they're healthy, can be relatively quick. And so these cells are around for a prolonged period of time. Again, we talked about tissue residence, right? And another important thing about macrophages is they have different, we'll say different versions of macrophages, right? The main two being M1 macrophages and M2 macrophages. M1 macrophages are inflammatory, right? Important for fighting infection, and we'll talk about the inflammation process hopefully a little bit later today. And M2 macrophages are suppressor macrophages. Why would you want to suppress an immune reaction?
Your immune cells are overactive, so like if you have cancer or something.
Well, yes, if your immune cells are overactive, typically if you have cancer, for the most part, you want your immune system, yeah. Right. But your first statement is correct, right? So the immune system, when it gets going and when it's activated and when it's hyped up, I would say, right, a kind of unscientific way to say it is it has trouble slowing down or it has trouble stopping, right? It becomes kind of the downhill snowball effect. And so you need something to rein it back in. And so these M2 macrophages help to assure you that the immune system does not overreact, right, or doesn't keep doing its thing when an infection is no longer present, right? So typically when that happens, right, not cancer, lack of suppression is a hallmark of autoimmune disease, right? And we'll talk about next unit, you also have T regulatory cells, right, a specific lymphocyte that is important in trying to suppress an immune response. So, you know, one of the important things in all of biology is something called negative feedback, right? So basically, when you move away from a set point called equilibrium, your body responds, it turns something on. Well, in all biological systems, if you turn something on, you typically want to be able to turn it off. And so suppression by M2 macrophages and T regulatory cells allows you to turn something off. Yes, ma'am.
Can it go back to M2? Like once it's gone to the inflammatory or suppressor state, it can't go back again? Like
Ooh, that's a good question. I would have to double check, but once a macrophage is activated, to the best of my knowledge, and again, biology, there's always exceptions to rules, it doesn't revert back, right? It does its job, and then it typically undergoes apoptosis. But I can double check, and I'm sure someone has found some example, right? But on a whole, we would say no, right? Once it gets activated and has its kind of specific goal, then it goes for it. Good question. All right. Another thing, this is really, really interesting. Macrophages can form something called giant cells. And so in the case of a giant cell, what happens is a macrophage encounters a pathogen. And we'll go over this a little bit later. Some pathogens actually are really good at surviving inside of macrophages. And so the macrophage is actually unable to digest that pathogen. It realizes this, and then other macrophages actually start to surround this macrophage, right? And such to lead to the formation of this giant cell. And then it actually goes a step further. You actually have T cells and B cells that start to surround this macrophage that can't digest this pathogen. And this forms something called a granuloma. So what's a disease that you guys have probably been tested for if you've ever had a job, right? Especially a job in any type of healthcare setting, that granulomas form. Tuberculosis, right? And so that's what happens, right? The mycobacterium that causes tuberculosis actually does a great job of surviving in something called a phagolysosome. A phagolysosome within a macrophage, that's where the pathogen gets digested, it gets broken down. There's a bunch of free radicals, right, which are damaging to cells. There is acid, there's enzymes, right, and normally that breaks down a pathogen and it's fine. Mycobacterium, along with other bacteria, have adapted and survive in this instance. Your body realizes that it can't handle it, and so it forms a granuloma. It walls off the pathogen to keep it from entering circulation. All right? And so this is one of the reasons that you can actually have latent TB, so you can have a bunch of these granulomas and not spread the disease and not be showing any symptoms. But in some patients, right, those granulomas, right, break or the bacteria escapes, and then that can be one of the causes of active TB in a patient. Okay? And again, for TB, it becomes an issue because when you start replacing lung tissue with granulomas, then you start losing the ability to take in oxygen. Yes, ma'am.
How do you get rid of that?
Whew. So we can talk about TB a little bit. It's hardcore antibiotics. Sometimes what can happen is the granulomas can be dominant in certain lobes of the lung. And so you could actually remove an entire lobe if it gets really bad. So you have to actually get rid of the granulomas, right? You have surgery, or you can have antibiotics. And again, depending on when you intervene in the infection, that's going to be different. And we'll talk about that. But antibiotics for tuberculosis, typically low-end time frame is 6 months. Sometimes you can get antibiotics for up to a year. It's a very tricky bacteria. We'll talk about this. Mycobacterium divide really slowly, and so they're not as susceptible to antibiotics, so you have to increase the dose. They're also really good at adapting to antibiotics, and so a good treatment for tuberculosis is actually 2 antibiotics for that time period so that you can try to overcome their ability to adapt.
So do you alternate the antibiotics?
No, you take them together. You take them together at once. And now we're seeing, like everything else, there are some forms of tuberculosis that are resistant to both antibiotics. And it's not something you can really vaccinate very well for. The TB test that you guys have all had was actually the first vaccine that was kind of ever developed, but it doesn't really work as a vaccine, but we did kind of repurpose it for that test. All right, so we talked about dendritic cells. I'm not going to really get too big into the myeloid and the plasmacytoid dendritic cells. You can see there are slightly different roles. For the sake of this class, as long as you remember, that they're kind of scavengers that are linking the innate and adaptive immune system together, that's going to be the big thing. We'll talk about cytokines a little bit later, but a little preview. One of the ways that they are bridging the innate and adaptive immune system is the cytokines that they produce when they interact with cells from the adaptive immune system are what lead to activation. All right, so dendritic cells release signals that will activate adaptive immune cells, which we'll see here in the next unit. And again, dendritic cells, antigen presenting cell, right? That is its job. It is presenting fragments of phagocytized pathogens Or, right, it can present fragments of something that's from the host, something that's not bad necessarily, presents it to the immune system. The adaptive immune system decides whether or not it needs to respond. So again, we'll talk about that process in a lot more detail coming up in the next unit. This is actually a macrophage extending out pseudopodia to grab bacteria and bring them in and phagocytize them. Okay? So, I mean, I love fluorescent microscopy. And sentinel. This is, one thing I just wanted to kind of put back to neutrophils. So neutrophils can also phagocytize, right? They have a lot shorter lifespan. Again, if you remember, they're the most abundant white blood cells, so turnover is quick. Right, they can phagocytize, but one other cool thing, and I can't remember if I mentioned it, is something called the neutrophil extracellular tract. And so here you can see a neutrophil, and you can see bacteria, and it kind of looks like it's stuck in a web. That is actually the neutrophil's DNA that it expelled, right? DNA is naturally sticky. The bacteria becomes stuck in this DNA, and there are also granules embedded within the DNA that are cytotoxic to the bacteria. So from a biological sense, right, this is a suicide mission, right? The neutrophil does not expel its DNA, kill the bacteria, then suck its DNA back in and go about its business, right? This is a one-way ticket. However, right, because they are so abundant and because their turnover is so quick, right, the body can easily replenish and replace the neutrophil or the neutrophils present in circulation. So it's just another really interesting way that these neutrophils can do their job. So let's briefly talk about phagocytosis. And I just have these steps listed here, but you'll see the next slide is an image, a picture that is showing these different steps, right? So recruitment, and again, we'll talk about this more throughout this lecture. We'll also talk about it a little bit in the next unit, because a lot of these same steps apply to adaptive immune cells, right? So you have to be recruited to the site of infection, right? Macrophages, dendritic cells, neutrophils, they have to know where to go, right? They have to recognize the pathogen. That's really important, right? If they can't recognize the pathogen, you can't control the infection, right? They have to engulf or take in via endocytosis, right? They have to mature, right? Be activated, right? Kind of related to Jada's question is once they're activated, can they go back, right? And before they're activated, although they are still a monocyte or a macrophage, they don't have the capability of digesting or breaking down pathogen, right? So maturation allows them to digest. And then they can expel via exocytosis, right? The fragments or the waste. And as I mentioned before, right, you can put a little slash and or present the fragments of whatever they ingested. So here's, again, these same steps, right? So chemotaxis, right? That is how, right, pathogens, or not pathogens, well, it could be pathogens actually too. That is how macrophages or dendritic cells know where to go, right? Chemotaxis, think of it as a breadcrumb trail that cells can follow to the site of injury or to the site of infection. One of the things that we will talk about a little bit later is pathogens also can follow the same basic principle to their food source, right? And so nutrients, right, form a chemical gradient that bacteria and other pathogens can follow to the site of whatever they want, right? Recognition and attachment. You'll see here that phagocytes have specialized receptors that allow them to interact with the pathogen. We'll talk about those receptors in a little bit more detail. We'll talk about what they are recognizing in just a bit, right? Once there's recognition, they can engulf, right? This is endocytosis, right? At its most basic principles. Once that pathogen is entered, right, You then have a phagosome, right? So again, that's the membrane around that pathogen. It forms with a lysosome, forming a phagolysosome. Again, within the phagolysosome, you now have enzymes, you have free radicals, you have a lowered pH, right? A bunch of acid. It's a really hostile environment. It breaks down the pathogen, right? And you can then expel it via exocytosis. But as I mentioned, some of those fragments would then be presented on the surface of that cell to be surveyed by other cells in the adaptive immune system. Right? So that's the basic principle of phagocytosis. You can see, right, by that image above, right, that is a macrophage, again, the pseudopodia that are reaching out and grabbing multiple bacteria, right? So you can pull in multiple bacteria at once. Right? It's really cool how the cell can stretch and bend its cytoplasmic and cell membranes, right, to reach out, right? So this is not just kind of a nice uniform looking process, right? It will reach and expand in whatever direction it needs to try to go after those pathogens. So I've already mentioned this, but those of you that go into some type of medicine, whether it be a nurse practitioner, PA, MD, DO, whatever you want to do, right? One of the things that is easily done, right, on a visit is that differential white blood cell count. And when physicians are looking at this, they're looking for the increase in certain cell types, all right? And so again, I've mentioned this, I think, before. An increase in eosinophils indicates some type of parasitic infection, right? Could also indicate some type of asthma, right? It does not always have to be a pathogen. Bacterial disease, right, often shows an increase in leukocytes and neutrophils, and viral diseases often show an increase in lymphocytes. Interestingly enough, you could put a slash here and say decrease. Some viruses are actually really good at suppressing lymphocytes, and so doctors might actually see a dip in that number, and that could also be indicative of a viral infection, right? When we talk about physicians, this is a really powerful tool, especially in infants and toddlers who can't really communicate exactly what's wrong. You can tell they're sick, but you might not know how to treat them. And so this might give you an indication, right? If you see an increase in these neutrophils and other leukocytes, well, then you know it's probably bacterial, so you can prescribe an antibiotic. If you don't see an increase in those, right, and they're still sick, and maybe you see a slight variation in lymphocytes, well, you know it's viral, and you're just going to give them Tylenol and unfortunately tell the parents to wait it out. All right? I've never found myself praying so often for a bacterial infection when I take my daughter to the doctor, because at least I know there's some type of medicine I can give her. The Tylenol regimen becomes old very quickly, right? We don't really get into it in this class, but I think you guys can appreciate for most viral diseases, by the time you come in and are presenting with symptoms, it's too late for any type of antiviral medication to take place, right? And so if you've had the flu, have any of you been to the flu and have ever gotten a line from the doctor? If you would have come in 2 days earlier, I could have given you Tamiflu and it would have been better, right? That's like, I just don't even tell me that, right? But that's just kind of the way it is, right? So treating viral illnesses with medications that actually address the virus is not actually that common. Viruses, it's typically symptom management, while bacteria is actually an antibiotic, right? So this is a really important section that usually makes me really sad when I look at your exams. This upcoming exam, and then I usually put a question just like this on the final. And I can say this with confidence, knowing that I feel like I'm still giving you nothing, because some of you may disappoint me, but some of you hopefully won't, right? All right, good. So this is a small section on something called pattern recognition receptors, right? So how are cells in our bodies recognizing really quickly what's foreign, or right, the alternative is what can we ignore, right? What's something to not freak out about? And so a toll-like receptor is a type of pattern recognition receptor. And pattern recognition receptors, of which a toll-like receptor is one of them, recognize something called PAMPs, pathogen-associated molecular patterns. All right. When a cell recognizes a PAMP, right, it can do a couple of different things. One, it can secrete inflammatory mediators, right? So it can start to release molecules, right, that induce inflammation and attract cells, right? It can cause vasodilation, right, which allows more cells to come in to the area or site of infection, as an example, right? It can stimulate an adaptive immune response. One of the things that I really want you to also start appreciating is that a good adaptive immune system does not do anything until it is signaled, right? And this can be one of those signals, or, right, upon recognition of a pathogen-associated molecular pattern, apoptosis can be induced, right? The idea of if the pathogen wants it, well, one of the ways you can keep it from the pathogen is to destroy it and get rid of it. All right. This is not a novel concept. All right, Jada, when you see that red octagon, what do you think? Okay, good, right? We'll see. We'll go with Sarah. Sarah, when you see that one to the right of it, what do you think of? Basketball, right? That's the NBA logo. What's that thing on the right? That little flying thing. What type of butterfly do you know? Yeah, monarch butterfly. And then what would you do if you were hiking and you saw this?
Run.
Yeah, I mean, I would run. Maybe there's some environmentalists out here that would, try to pick it up. Right, Sarah, you like the environment, right?
Yeah, but not snakes.
Not snakes. Okay, good. So we all have our point, right? If you're like red and yellow, you're a dead fellow. Red and black, you're okay, Jack. Right. So this is a coral snake. And so we have been conditioned, right, to recognize certain patterns, right? To Jada's point, the red octagon. Every time Jada's driving down the street, she doesn't see a red octagon and then has to read it and process it, right? It becomes secondhand nature. She sees that and she does not have to, right, take the time, right? She just recognizes that pattern. You guys have seen these patterns, you know them. And this is kind of what's happening in the innate immune system, right? Your cells have been programmed to recognize certain components of pathogens, right? So they see this and they know it's foreign. So as I mentioned, toll-like receptors are one of the best, right, mechanisms for identifying pathogens that the innate immune system can do. Those of you that have had genetics, which I think is probably a lot of you, you guys did fruit fly work. And so this is why we call them toll-like receptors. The toll receptor was actually discovered in fruit flies. Basically, they noticed that certain fruit flies were succumbing to a fungal infection really easily, and they looked at them and found out that they were lacking a toll receptor that their brethren that weren't dying had. You can see you have different toll-like receptors for different pathogen components. You also have, right, toll-like receptors that are embedded within the cytoplasmic membrane of cells, and then you have toll-like receptors that are hanging out in lysosomes, right, that can recognize pathogens that have made it into the cytoplasm. All right. We find toll-like receptor expression very, very heavy on epithelial cells. Remember, epithelial cells are lining cavities or openings that pathogens might try to breach in order to cause infection. All right. So you see one of the toll-like receptors that we talk about the most in microbiology is toll-like receptor 4, right? it is interacting with something called LPS, which we'll talk about a little bit later. But you also see that you have toll-like receptor 11, right, that can interact with a molecule called propylene, which we find on protozoa parasites. You see here in some of these cytoplasmic toll-like receptors, they can interact with viral DNA and RNA, and that makes sense that would be in the cytoplasm because that's where viruses are going to be hanging out. You also see you have a toll-like receptor that can interact with bacterial DNA. All right, and so these toll-like receptors, which are under a broader category of pathogen recognition receptors, right, or pattern recognition receptors. I'm sorry, but I don't care if you call it pathogen recognition receptor. That's fine too. When your cell, right, gets a ping on one of these receptors, it leads to some type of activation or response. Now, one thing I won't have you memorize, but maybe if you were in cell bio, I would make you memorize this, but you're not, and I just want you to appreciate more of exactly how things are being activated, right? Is that you have basically activation of receptor leads to a signaling cascade. And if we really wanted to simplify it, activation of the signaling cascade, right, leads to the removal of I-kappa B, which is an inhibitor of kappa B, from NF-kappa B. NF-kappa B, right, is a transcription factor. And when I-kappa B is removed from NF-kappa B, it allows it to move into the nucleus of a cell where it acts as a transcription factor, right, for some of those inflammatory cytokines that we talked about, some of those mediator cytokines, maybe even leading to the induction of apoptosis. All right, so that is really what's happening when a toll-like receptor recognizes something, right? Essentially, it's driving NF-kappa B into the nucleus where it acts as a transcription factor, where those genes, right, can be produced that lead to some type of immunologic response. Okay? But I am not going to, say, make you recognize or remember TRAM, right, or TRAP6. Unless you really want to, right? But I just want you to kind of appreciate the basic premise of what's going on. This is, again, just kind of a brief description. Dr. Crispin made this a while ago, and I've kept it. But you're assuming that we're in the cytoplasm inside a cell, so here's the nucleus. Right, NF-kappa B, which is that transcription factor, cannot enter the nucleus because I-kappa B is bound to it. Right, so that's my friend Nemo. I will just say, Finding Nemo, one of the most overrated Disney Pixar movies ever. Right, you can come to my office and prove me wrong at another time. Right, this is also Captain Nemo from 20,000 Leagues Under the Sea. But basically what happens is Nemo stands for NF-kappa B essential modifier. So this is another molecule that has to come into play, right? It binds to I-kappa B, and it allows NF-kappa B to then move into the nucleus where we have transcription of those genes that are mediating inflammation or mediating immune activation, all right? And this is all started, in this case, when a part of a pathogen or a whole pathogen binds to one of those toll-like receptors, and we get what's going on. All right. Now, it turns out if you go back to that image that I showed with the toll-like receptors, there's a couple other things in the cytoplasm. One of the other things in the cytoplasm are nod proteins, right? So they hang out in the cytoplasm, right, and they bind pathogen-associated molecular patterns, just like toll-like receptors, right? And they have very similar function, right? Inflammation, apoptosis, and another innate responses. We have a pretty good, right, if you go back a couple slides, good idea of the signaling cascade, right, that is induced when a toll-like receptor is bound to, nod-like receptors, right? We are still learning about them right now, but we know they're in the cytoplasm, and so the pathogen has to be intracellular in order for them to be activated. Ooh, this is a good one, and it'll allow a brief discussion of maybe one of the papers that you guys read. So another important response from toll-like receptors can be the production of interferons. All right? And interferons are great, and this is actually a really important concept because they non-specifically inhibit the spread of viral infections. All right? Now, one of the unpleasant things is a lot of the unpleasantness that you experience during a viral infection, right, is actually being caused by these interferons, right? You have two types, type 1, which includes alpha and beta, and type 2, which includes gamma, and we'll talk about those in just a second. Truth be told, gamma is going to be great at activating macrophages. Now, who would like to take a crack, or who remembers why this basic concept of non-specific viral inhibition, right, could be relevant to COVID-19? Something that you guys read. Right. So the basic premise, right, of that one kind of paper that was a commentary was simply saying, does anyone remember what vaccine it was referring to? OPV, which is what?
Polio vaccine.
Yeah, oral polio vaccine. Do you remember, or can you tell from there? So if we had to categorize vaccines, and we'll talk about this more, but there's two basic categories. So the oral polio vaccine would fall into what category? Y, right? Your other option is inactivated. And so one of the things that talks about in the paper, right, you don't see the same benefit from inactivated vaccines. Right? And so Rachel is right. The basic premise is that OPV, in this case, showed protection against other viral infections because when you gave that vaccine, it produced an interferon response. And that interferon response interrupted, right, other viruses that may have been introduced to the system. So, why is this actually not beneficial for the most part in the case of the flu vaccine? Right? So that's a big season, right? So this is one of the again, from the potential illness, not exciting for people, but from an epidemiological, microbiological, biological concept, right? The intersection that we're about to have of the flu season and the COVID-19 pandemic is going to be really scientifically interesting. All right. So why would getting the flu vaccine not help here? So I'm telling you, for the most part, it wouldn't help. So what does that tell you about the flu vaccine? It's an inactivated vaccine. Why? And I will tell you, there is an attenuated flu vaccine, right? It's not as commonly used. Why do we primarily use an inactivated flu vaccine? We're just doing this now. I love vaccines. Why is it safer?
Because you're not giving a live virus, because they can still get sick.
Okay, so yes, I like that. But Jada, for the most part, would it matter which one I gave you?
Me?
Yeah.
No, but someone who's already at risk, yes.
Exactly, right? And so this is, one of the things we'll talk about in vaccines is that, people, for whatever reason, right, might be higher risk. One of the people groups that is at most high risk for influenza, right, are elderly. elderly, right, don't have as good of an immune system. What's really interesting is that actually when you're a teenager, right, is when your thymus, right, which is where T cells are educated, is most active and doing its best job. After that, as you age, all of that, your thymus starts to be replaced with fatty tissue. And you're no longer able to produce that really, really diverse array of T cells, which is one of the reasons, right? As you get older, you become more susceptible to certain infections. And so using a live virus on someone that is really old or someone that's immunocompromised for a variety of reasons is not the best option. No matter what your immune system is, as long as the virus has been inactivated correctly, which there have been some issues with that before, you're not going to get ill. You know, one of the things that kind of gets overlooked in the campaign against polio was really early on. One of the companies that was making, so Dr. Jonas Salk's polio vaccine was actually an inactivated polio vaccine, and one of the companies that was making it failed to inactivate the virus properly, and so they basically gave a bunch of people polio, right? So definitely one of the anti-vaccinations movement's first strongholds. And I can understand someone being upset if they went for polio vaccine and got polio. So yes, ma'am.
So with the flu vaccines, what is the difference in the normal flu vaccine and those for elderly patients?
Well, so there, actually, I could give you a really interesting paper right, that kind of breaks them down. There's a bunch of different categories of inactivated vaccines. And so most doctors offices are just going to carry the inactivated vaccine. There are some of the inactivated vaccines that have been shown to be more effective. I have to check the age range, like on 65 and plus. But for the most part, the majority of flu vaccines that are being carried by your doctors, by Walmart, Walgreens, wherever you go, are just going to be inactivated because it's just a safer bet, right, when you're treating patients. So, you know, I could look up, I could show you the specific vaccine names, but they're primarily going to be inactivated just across the board. The live attenuated is just not used that much.
So
Because you
the
don't
ones
understand.
for patients under 65 are typically attenuated?
No, they're typically actually inactivated. Just because doctors, like, they're just, it's easier to carry the inactivated and then not have to worry about necessarily who you're giving it to. So the live attenuated flu vaccine is one of the least common flu vaccines that's used, all right? I also have another interesting theory that has not been substantiated yet, but maybe it will be at some point. What's the age group that appears to be least susceptible to spreading and or dealing with any type of symptoms from COVID? Ooh, and what age group has most actively been vaccinated? 0 to 5. I mean, when you're those first, 3 to 4 years of life, that's when you're up on all of your vaccines. And so, I mean, this is one of Professor Daff's crazy theories when he reads literature that, he does not have the time to substantiate or prove. But, so we'll actually start here with the basic premise of the interferon response. I don't want to keep you guys long. I want you guys to get enough time to wipe down your stations and areas. So we'll finish up with the innate immune system, specifically spending some time on inflammation on Wednesday, and then we'll jump into the adaptive immune system on Wednesday or Friday. All right? Get out of here. If you haven't turned in that paper, right, I will extend and show a little bit of grace if you did it in this morning. Okay? Cool. Ooh, that's a a little bit of both. So for the master's homework, what I will try to typically do is go and look through it and pull a couple questions and see what we covered there. I definitely would say I'm more note and lecture heavy But, you know, one of the points of the master plan is supposed to go into the textbook a little bit. So, I guess if you had to, like, if you had to choose one over the other, I would definitely choose probably lesser notes. But the textbook with the mastering still plays a significant role. For the most part, though, again, I'm trying to pull from the text and then kind of add in like a little bit of extra. And so the text is never a bad idea. You know, certainly the time is not contradicted. I'm not thinking that would happen. But and I wouldn't. If there is something contradictory in the text, and there's multiple reasons it could be contradictory, I would not pull it from the text and expect you to answer it like the text. The first one, I mean, I'll just it's always a little bit of an adjustment for people that haven't had it or anything. But you will find all my exams follow almost the exact same format and my expectations.
Sorry.
And so, I mean, I don't say that to worry you, but I'm also, you know, like, there's just a little bit to kind of learn. Okay. But I mean, as you study and look over stuff, if you have questions, please get over it. I think I have some like, practice kind of questions. Let me check and see if I still have those up there. If I don't, I'll put some of those up there. Just kind of like big concepts. I love the big concepts, but I will be honest, I love the little details too. So like if I give you a 10-point question and you got the big picture, right? You know, I'll say that big picture is probably worth 8 of those points. And then some of the fine details are what puts it over the top. It doesn't happen. It's not, I mean, people can get really good at I'm not saying that I'm awful, but you know, I expect big concepts